OK，好，谢谢。Welcome back to the symposium, ladies and gentlemen. We are very delighted to have Professor Hiroshi Matsuda from Fukushima Medical University to give us the third and fourth speech of today, which starts with a lecture titled ATN Profiles using amyloid and tau PET in patients with cognitive impairment and suspected Alzheimer disease, followed by a session of neurologic image reading. Let us first welcome Dr. Bai Yi Qiu from Xiuchuan Memorial Hospital for moderation of the lecture session. Please, Dr. Qiu. 谢谢。
我还是用英文的哈，我们介绍国外 speaker 哈。Professor Hiroshi Matsuda, he is a graduate with a degree in medicine at the Kanazawa University School of Medicine， 就金泽大学了哈，医学系毕业了哈。He finished his doctor's course at the Graduate School of Kanazawa University School of Medicine. Then he had a Rotary Foundation scholarship in Montreal Neurological Institute。这个蒙特利尔的这个 Neurological Institute， 培养出非常多的这个很有名的这些的大师们哈。Now he is the professor of Department of Biofunctional Imaging, Fukushima Medical University. He also spent some time in being the director of Drug Discovery Research and the Cyclotron Center, Southern Tohoku Research Institute. He is also a former Director General in the Integrative Brain Imaging Center, National Center of Neurology and Psychiatry. So he will talk about the ATN profiles using amyloid and tau PET in patients with cognitive impairment and suspected Alzheimer's disease. We know that you can diagnose Alzheimer's disease only with amyloid PET and tau PET or CSF were both positive. If you have only one amyloid, you can diagnose an Alzheimer's pathological. And so we welcome Professor Matsuda to have this talk. Thank you.
Thank you for your introduction, and it's a great honor to meet this invitation. It's a great honor to me. Thank you very much. So today I will talk about the ATN profiles using the amyloid and tau PET for diagnosis of Alzheimer's disease. So this is a COI. So you know the two main pathology is present in Alzheimer's disease. One is beta amyloid deposits in neuritic plaques and extracellular presence, and the other one is intracellular neurofibrillary tangles, especially the paired helical filaments. These two neuropathological findings induces the loss of synapses and neurons in Alzheimer's disease, so it's well known. And early symptoms of Alzheimer's disease is many symptoms, but most common symptom is memory loss. So this is a very characteristic symptom for Alzheimer's disease. So however, the early diagnosis of Alzheimer's disease in daily clinical practice is not so easy. So in daily clinical practice, the formal mental status examination, the history and physical examination, and the laboratory testing, and the neuroimaging, the MRI, CT, FDG PET, and brain prospector, and so on. However, this daily clinical practice does not provide us accurate diagnosis of Alzheimer's disease because this is our multi-center study using the flutimethylmol, so in Japan. So we studied 93 patients with cognitive impairment or suspected Alzheimer's disease. MMS is 21.2 on the average. So before amyloid PET, very high likelihood of Alzheimer's disease. this group has only 79% of the amyloid positivity. So high likelihood of amyloid, Alzheimer's disease group has only 60% of amyloid positivity. So the 30 to 40, 20 to 40% are misdiagnosed as Alzheimer's disease. So this is our recent study using the flow beta PET. So in this study, some more mild cases. So 54 subjects with diagnostic confidence above 50%. This group has only 52% of amyloid positivity. So 48% is misdiagnosed. So it's very difficult without amyloid PET for diagnosing early Alzheimer's disease. So why, the reason why the Alzheimer's disease diagnosis is very difficult in early phase of Alzheimer's disease. I think the Alzheimer's disease and no-Alzheimer's disease has many overlaps in MRI, CT, and FDG PET findings, and also the symptoms overlap in these Alzheimer's disease and no-Alzheimer's disease. So this coexistence or overlap is more prominent in older age. So this diagnosis is not so easy. So the biomarker-based diagnosis of Alzheimer's disease is proposed by Jack and his colleagues. And so they said the amyloid A, tau T, and neuronal injury and ATN profiles are very accurate for diagnosis of Alzheimer's disease. If both A and T are positive Alzheimer's disease, we can diagnose Alzheimer's disease, regardless of whether neuronal injury is negative or positive. In this meaning, the rate of neuronal injury is not so high in Alzheimer's disease diagnosis. So in this profile, so amyloid and tau and neuronal injury has positive or negative. So the 8 profiles are present using this ATN based ATN classification. So if A plus T plus the Alzheimer's disease, N minus or N plus is the regardless. And so if A plus is the Alzheimer's continuum, so if A minus is not Alzheimer's disease, no AD Alzheimer's disease pathologic change. So at first, I'd like to talk about the amyloid PET. So you know the amyloid cascade theory is proposed in familial AD and sporadic AD. So in familial AD, the production of amyloid beta is increased. On the other hand, the sporadic AD, the clearance of amyloid beta is disturbed. So eventually, the amyloid beta increases in the blood, in the brain, and it causes oxidase injury and neuroinflammation. And then the neural rate changes occurred. So the dementia, eventually dementia occurs. So this is the amyloid cascade theory. In this cascade theory, the amyloid accumulation is the initiator of these changes. So recently, we demonstrated the glyphatic system activity measured by MRI diffusion tensor imaging and amyloid accumulation. If glyphatic system activity decreases, in other words, clearance is decreased, so amyloid accumulation, amyloid deposits increases in the temporal parietal area. This finding supports the in sporadic AD, amyloid clearance is disturbed. So we have 5 kinds of the amyloid PET tracers. So the PIB, fluorobutapyl, flutemetamol, fluorobutapyl, and NVIDIA 4694. So the amyloid PET interpretation based on visual reading. So in the negative, non-specific white matter accumulation is present. The positive findings, we have to pay attention to the amyloid accumulation in posterior cingulate gyrus and precuneus, frontal cortex, the temporal cortex, the parietal cortex, and the striatum. So I will show you the typical negative and positive cases. In the cerebral level, the upper panel is negative, lower panel is a positive case. So even in the positive case, the cerebral cortex shows a low accumulation. This is the pons level. We can see high accumulation in the cerebral cortex in the positive case. And the pons has white matter content is very high, so accumulation is high even in the positive case. So the mid-brain level, so the frontal cortex and temporal cortex shows a high accumulation, but hippocampus shows a low accumulation even in the positive case. And the basal ganglia level, so we can see accumulation in the internal capsule, the white matter in negative cases. The positive cases, you can see cerebral cortex accumulation and striatum. So the lateral ventricle level, the caudate body shows a low accumulation in a negative case. So posterior cingulate gyrus and precuneus shows a high accumulation in positive case. The centrum evole level, so you can see a high accumulation in the precuneus. This is a typical case. And in sagittal section is also very useful for diagnosing positivity. You can see high positive cases in the medial prefrontal area and the posterior cingulate gyrus and the precuneus area. This pattern is very characteristic for positive case. So parasagittal level, you can see high accumulation in the anteroventral striatum. So the striatal activity usually is more common in anteroventral striatum, maybe correspond to the nucleus accumbens around area. The corner images, we can see internal capsule activity in the negative case, and the positive case is the cerebral cortex shows a high accumulation, but hippocampus shows still low activity. So summary of positive findings amyloid PET. So high accumulation is observed in posterior cingulate gyrus and precuneus, frontal cortex, and temporal parietal cortex. High accumulation in the striatum, and low accumulation in pericentral sulcus area, occipital lobe, and hippocampus. So lowest accumulation in cerebral cortex. So, however, familial Alzheimer's disease, this is a presenil1 gene mutation. In this familial Alzheimer's disease, we can see a very remarkable accumulation in bilateral striatum. So, if you see this kind of the amyloid PET, you have to consider this patient maybe familial Alzheimer's disease. So the visual interpretation is very important. However, the visual interpretation positivity varies from reader to reader. So the concordance rate is not so high, especially using the fluorine 18 labeled tracer. So to help the visual interpretation, the quantification of amyloid PET is proposed. First one is the standard uptake value ratio. SUVR, it's a very simple equation. Ratio of specific accumulation over non-specific accumulation. The other one is a very harmonized scale. So this is a stage of amyloid accumulation calculated on the basis of PIB PET, carbon 11 PIB PET from 0 to 100. So this central scale is conversion. We use a conversion equation using a regulation equation between PIB PET and fluorine 18 labeled PET. So the central scale is very useful for a very simplified expedited direct comparison of A beta PET results across sites and PET tracers used, and very robust index scale, and so we can set a threshold for a positivity using the central scale. So this is a central scale basis. So in the central scale 0, so using the PIB PET, this is a 0 images. You can see only a high accumulation in the white matter, not accumulation, no accumulation in the cerebral cortex. This is a central scale 100. So we can see posterior shingles, precuneus, prefrontal area, cerebral cortex, and pericentral area is slightly low activity, and almost no accumulation in the hippocampus. So this central scale is very useful for harmonization. So if we choose the reference area, the whole cerebellum or cerebral gray matter or pons or brainstem, so the CVR varies from reference area to reference area, but the central scale provides us almost same value central scale. And so if we use the different tracer, so using these 5 tracers, the central scale is almost equal, around 60, but the SUVR depends on the it varies from the tracer to tracer. So it's very useful scale. So if we compare the visually negative cases and the central scale, 0 to 14 is the left side, the visually positive case 35 to 19.7. So in these cases, it's very rather easy for us to differentiate negative or positive. However, so central scale from 12 to 30, it's called the gray zone for visual interpretation. So it's very mild amyloid accumulation. Sometimes very difficult for us to detect abnormality. So in this area, gray zone, the central scale is very useful for defining the positivity. So we developed recently for software for measuring the central scale and comparing patient data with a normal database, a negative normal database, G-score analysis. So this is a result report. So automatically we can get the central scale here. And this is a comparison of patient data with the control database, the brain surface, and tomographic area. So I'll show you the utility, usefulness of this software. So equivocal case by visual interpretation using the fluometer mode. So what do you think? This is positive or negative? So I was very, I cannot make a diagnosis definitely. So in this case, so there's a positive central scale 23, and we can see accumulation, statistically significant accumulation in the posterior cingulate precuneus and the medial prefrontal area. The other case is a fluorobetapia. So also the visual interpretation, the positivity differs from reader to reader. So at the first glance, this may be a negative, but somewhat increased accumulation around here and around here. So in this case, the central scale is 32. So the definite accumulation in the posterior single gyrus and the precuneus. So the central scale is very helpful, and the G-score analysis also very helpful to detect regional abnormality. So both the central scale and the G-score analysis are very helpful for diagnosing the AD possibility, positivity. So then I'd like to talk about the tau PET as a visual interpretation and the quantification. So this is my opinion. So tau PET tracer requirements for Alzheimer's disease diagnosis. I think this tracer does not bind to any other proteins, such as amyloid beta protein, TDP-43 protein, or alpha-synuclein. Should not bind. And it should bind specifically to only 3-repeat 4-repeat tau, but not to 3-repeat or 4-repeat tau alone, because the 3-repeat tau is observed in the Pick's disease, and the 4-repeat tau is observed in the progressive splenomegaly, cortical basal degeneration, algiographic brain disease. Especially so, algiographic brain disease induces medial temporal atrophy. It's like Alzheimer's disease. If the tracer accumulates in the medial temporal area, so if this tracer binds also to 4-repeat tau, which we as a diagnosis, it's AD diagnosis misdiagnosed for as Alzheimer's disease. So this tracer should binds to only 3-repeat 4-repeat tau. This is a mixture of this mixture of 3-repeat 4-repeat tau is observed Alzheimer's disease, senile dementia of the new Fabry Tangus type, and chronic traumatic encephalopathy. So in chronic traumatic encephalopathy, the tau accumulates in the cortico-medullary junction area, not the medial temporal lobe. And SDNFT accumulates in the medial temporal area, but this is amyloid negative. So using the ideal tracer, we can diagnose Alzheimer's disease very correctly. And of course, the low off-target accumulation is necessary. It should not bind to monoamine oxidase, but it should not bind to colloid plexus. So the tau PET visual interpretation is depends not a positive or negative. We have to measure tau PET in visual interpretation based on Braak stages. So rather than the positive or negative decisions, the Braak staging has 6 stages. Stage 1 or 2 is a transantennal area, localized accumulation in the transantennal area, transantennal to entorhinal. So stage 3, so this accumulation extends to the limbic area and posterior single gyrus and or basal frontal. And little bit, so little accumulation in the neocortex. Stage 4, we can see accumulation in the lateral temporal cortex. We call limbic stages. And then neocortical stages, the 5 to 6. So in 5 to 6 so neocortical stages, we can see tau accumulation in the posterior single gyrus precuneus. So in the 6 stages, we can see accumulation in the frontal area also. So already the black staging at tau PET is reported. So black one stage, we can see low accumulation, high accumulation is, sorry. Medial temporal area, and then extends to the surrounding area. Block stage 3 is fujiform gyrus, and block stage 4 is the lateral temporal cortex. Block 5 is the parietal cortex, temporal parietal cortex, and then block 6 is we can see frontal cortical accumulation. So we are now using the amyloid and tau PET tracers for AD research. For amyloid PET, already the professor Harding presented the fluorinating NVIDIA 4694, usually called the AstraZeneca 4694. I think the most superior fluorinating labeled amyloid PET ligand. So this is a less non-specific accumulation, and the equivalent was superior to carbon-11 PIB and large dynamic ranges. And this tracer is used in clinical trials as well as clinical studies. So easy to detect very mild amyloid accumulation. And for tau PET tracer, we are using the MK6240. So this is a second generation tau PET tracer. So most widely used in the world for research and clinical trial. This is a low off-target accumulation, and it binds specifically accumulated to the only 3 repeat 4 repeat tau, not binded to 4 repeat alone, or not binded to 3 repeat alone. So I think it's ideal for Alzheimer's disease diagnosis. So I'll show you images. We are using the solid-state PET-CT of United Imaging Healthcare. So FWHM is 3 millimeter. So the resolution is so very nice scanner. So in this case, the amyloid PET, the central scale is almost 0, the negative. And this MK is 60 to 40. So no accumulation in the cerebrum. But still little bit accumulation in the substantia nigra. This tracer binds to retina and ethmoidal sinus and the meninges. So it's related to the melanin or melanin site containing cells. So the melanin containing structures shows somewhat accumulation. And this is we are using the MRI for N factor. In this case, normal AD biomarker case. This case is a very mild accumulation in temporal cortex, right temporal cortex. Using the software, we can detect mild accumulation and mild amyloid deposition in right temporal cortex. Tau is negative, black stage 0, and MRI is also negative, A plus T minus N minus. In this case, the amyloid positive and tau PET shows a black stage 5 medial temporal cortex and parietal cortex and the posterior signal gyrus and the precuneus. And MRI shows positive. So the MRI is negative. So in this case, it's A plus T plus N minus. So if both A plus A and T are positive, the Alzheimer's disease, we can diagnose. So in this case, A plus T plus N minus. So in this case, the A plus T plus in this case, blood stage, I diagnosed the blood stage 4 because almost no accumulation in the parietal cortex, just a little bit accumulation, but mainly in the lateral temporal cortex. So I diagnosed blood stage 4. And MRI shows also remarkable significant atrophy in the medullary-temporal area. So we are using the we developed software VSRAD software for voxel-based morphometry. You can see a significant atrophy as a color map in the 3D T1 weighted images. In this case, so A plus, T plus, N plus. And this accumulation of MK6240 accumulation pattern is a kind of hook-like pattern. So this is a hook-like pattern means accumulation is high in amygdala and WUNX and internal parahippocampal gyrus. So in the sagittal section, this accumulation looks like a hook. So hippocampal accumulation is not so high. So this hook-like pattern, we can see a hook-like pattern. The reason why the hippocampus shows relatively low accumulation is not so clear, but this hook-like pattern is very useful for diagnosing the Alzheimer's disease using the tau PET. In this case, the A plus and T minus and N plus. So amyloid PET, the plus, but MK6440 is negative. So black stage 0. And N plus. So in this case, the amyloid positivity alone should not be enough to diagnose the Alzheimer's disease. So the tau PET is very important for definitively diagnose Alzheimer's disease. Amyloid PET is not enough to diagnose AD completely. And in this case, A minus, T minus, N plus. So cell scale is very low and no accumulation in and this N plus. So in this case, no AD pathologic change. So in this case, very interesting case. So in this case, MAC24 and Wechsler memory scale revised. This is memory recall. The immediate recall is only 5 of 25 score, and 30 minutes delayed recall is almost nothing. So the memory disturbance is severely damaged. But this is A minus, but T plus. So you can see accumulation in the medial temporal lobe area, so black stage 1. So in the hippocampal atrophy is very prominent in this case. So this case is senile dementia of the neurofibrillary tangles type. So this is a very slowly progressive dementia with abundant neurofibrillary tangle in the hippocampal region, more common in the late stage elderly and onset with memory impairment. So absence or scarcity of senile plaques, amyloid beta protein deposits are almost nothing through the brain, and 3-lipid, 4-lipid tauopathy, like Alzheimer's disease, and referred to as primary age-related tauopathy part. And this is the background of SNAP. SNAP means suspected non-Alzheimer's disease pathophysiology in the differential diagnosis of Alzheimer's disease. So before tau PET, we can diagnose this disease after postmortem neuropathology. But using the tau PET, we can easily detect this disease. So we are now, this is an ongoing study. So far, I examined using both tracers in 18 cases. So these patients are suspected Alzheimer's disease, but only 11 cases are amyloid and tau positive. So almost 60% is diagnosis is correct. So the tracers are very useful for accurate diagnosis of Alzheimer's disease. And also the tau PET quantification is reported, but still not harmonized protocol is established. But some researcher reported the region of interest is mesial temporal, temporal parietal, and the rest of the neocortex. So many studies have applied volumes of interest derived from free surfer analysis of 3D T1 weighted images taken in the same period of tau PET. And also standardized central scale has also been proposed for some second generation tau PET probes. So in the near future, so the central scale for tau PET may be published. So we are also using the free surfer volume of interest, and using the Python program, we set up region of interest automatically in several cortex and medial temporal lobe area, and so. So finally, the outline of amyloid PET significantly leads to change in the clinical diagnosis of Alzheimer's disease. To become proficient in the evaluation of amyloid PET, the combined use of visual reading and quantitative assessment using the central scale and Z-score analysis is very helpful. Second, tau PET provides accurate ATN profiles in Alzheimer's disease. This concludes my presentation. Thank you for your attention.
Thank you, Professor Matsuda. Is any questions for Professor from the audience? Yes, Professor Huang.
I'm Dr. Huang. I ask a question. Is there any tau PET can differentiate such kind of what kind of tau isoforms? Because now many isoforms they function different. So I don't know what the advantage, the progress of tau PET.
So the MK6040 only binds to 3-bit, 4-bit tau, not bind to 4-bit or 3-bit. So, but other tau PET tracer like PMPBB3, so it's in Japanese researchers developed. So it binds to also binds to 4-bit tau. So, we had better. So we have to use the tau PET tracers, different PET tracers to detect various tauopathy.
Okay, thank you.
Thank you, Professor. Is there any other question? Because the time is limited, we must move to the next section.